Our next speaker is Noel Alpins, and he'll be addressing the topic of astigmatism, where it is and how to measure it.
Well, thank you for the invitation to speak and also for choosing for me such an interesting subject. And it is a challenging subject, but we'll see how we go through it. So, my disclosures should have been there. My disclosures are there. So when you think about astigmatism, where it is, it goes all the way from the front of the eye to the occipital cortex. So there's the anterior cornea, which is obviously the most refractive surface, and the posterior cornea, which certainly has an influence. Lenticular astigmatism plays a part, and even tilting of the lens can be a factor. And then the visual cortex, which I call really the perceptual astigmatism, which can have an influence, certainly when you have a patient manifest refraction and they're asking for a particular cylinder and its orientation, even though it may not agree with the cornea. So if you're looking at the eye internally, whether you do an auto-refraction or a wavefront aberrometry, that's going to measure all the astigmatism all the way back to the retina. When you do a manifest refraction, it does all that, but it also takes you all the way further on to the occipital cortex. So let's just look at a patient's example. When you look at the second-order spherocylinder of a wavefront aberrometry, a cylinder being 1.07 at 101, and the manifest refraction being different at 1.75 at 95. So looking at it differently, they certainly can't be both correct, but there's certainly just different ways of measuring astigmatism. And so when you want to look at it and say, well, what is the difference between these two? You just do really what you call a vectorial difference. It's a relatively obliquely crossed cylinders subtracting one from the other. And the interesting thing here is the difference in cylinders between the internal astigmatism of the eye and then all the way to the occipital cortex, which is really the perceptual component. Remembering perceptual is non-optical, is 3/4 of a diopter, just doing a simple vectorial calculation. So, you know, when you do wavefront aberrometry, sometimes you want to modify it towards the refraction or vice versa. Which of these might be closer to the cornea? And just by looking at it this way, you certainly cannot tell until you look at what I call the ORA, or the ocular residual astigmatism, which gives you a vectorial difference between the refraction and the cornea. So lo and behold, when you look at the ORA for each of these two measurements of one eye, we're talking about the measurements of one person of one eye. In this case, the wavefront aberrometry cylinder is closer to the cornea and the manifest refraction is further. But it can go either way, so I don't think this is a trend that you'd want to depend particularly on wavefront aberrometry. So in other words, the point I want to make here, just to start off, even on a cataract type thing, is that if you're going to treat this eye by manifest refraction, and you're going to sculpt that using 100% refractive parameters for a laser surgery, for example, you're going to leave somewhere between 1/2 to 3/4 of a diopter of astigmatism extra on the cornea that isn't even correcting optical astigmatism. It's actually correcting something that's non-optical, the way the patient sees it, even though it's not an optical component. So you're going to leave a whole lot more astigmatism on the cornea for what is a non-optical component, which is important, even for also implant surgery, as I mentioned. So when you look at the ORA, the ocular residual astigmatism, it's a simple vectorial calculation comparing the refractive and the corneal values, also known as lenticular internal non-corneal astigmatism, but I don't think these are good explanations. I think ORA is the best way of describing it. Average for normal, healthy, astigmatic eyes is somewhere between about 0.73 and 0.81. Here we're using a double-angle diagram to be able to connect that to. And here's an important point, which I'm going to be talking about later this afternoon as well, is that the ORA in this series back in 1997 to 100 eyes was 34% more than 1, which is kind of what I call a red flag for ORA. And in another series, which is 1,500 eyes by Dr. Chen in China, it's 45%, and I'll be talking about another one as well this afternoon. So what we do when you do laser surgery is we kind of optimize it, so no matter whether you're further or closer to corneal values, if you use vector planing, you're going to take 40% off the corneal astigmatism, whichever way you look at it, which is favourable. So in this kind of mix of a preoperative corneal and refractive value, which could be a cataract or a laser, you have an ORA that, once again, is more than 1, it's 1.25. So what I do when I try to work out what the astigmatism of an eye is, and this is what we're talking about, is where is this astigmatism, I'm going to line it all up this way. On the left-hand side there, in the red circle, you can see the corneal values, and whichever ones you want to take from, I use SimK, Keratometry, and CORT total, but there's others that are available. And then across the horizontal, I use refractive ways of measuring a cylinder, such as wavefront, manifest, cycloplegic, could be auto-refraction, and refractive. And so we're going to do like a template and look at the ORA and do an ORA calculation here 9 times over to see which of these two numbers combination is actually going to give you the smallest ORA, because that is the best measure of the corneal astigmatism of that eye. So you can see, for a start, in the wavefront column and the manifest column, in this case, the wavefront was further away from the cornea than the manifest was, so I'm just showing you how it can go both ways. But actually, the best numbers for this particular eye was the keratometry and the manifest, because it had the lowest ORA. So what I would put into the laser, or what I would consider was the astigmatism in the eye, would be 1.25 at 163 using keratometry and manifest refraction values. So when you treat using a toric implant, fundamentally, you actually are lining up that implant with the corneal astigmatism. In other words, you're treating 100% by refractive cylinder, 100% by corneal astigmatism, and when there is an ORA remaining, it's going to be left behind in the refraction. Now, when you take out the lens, you're taking out the lenticular astigmatism, but that doesn't solve the problem. There is still astigmatism left over. As I mentioned, it could be, it can be perceptual, but also is what I call non-lens ORA. In other words, after taking out the lens, before you put the lens in, there still is a difference in the refractive and corneal values, which is going to affect your outcome, particularly for toric implants, because you might line it up with the cornea, but the patient, once again, might prefer the refractive value. And this is why, when you do a refractive surprise calculation, you don't always, the refractive surprise calculation that tells you to rotate it, let's say, in a clockwise sense by 15 degrees, it doesn't always take you to the steepest corneal meridian. In other words, I hear people saying, oh, I just re-rotated at the steepest meridian. Well, you won't get the best result that way. You need to rotate to the calculation you can get with those toric analytic calculators, and there's one on the ISRS website that I've built for the IRS for free to use. So measuring astigmatism, you have corneal shape and optical correction. You can do it at a basic level of keratometry and manifest refraction. You can do an auto keratoscopy, auto refraction, or you can go to a more sophisticated level of topography and wavefront aberrometry. So if you're faced with a topography that looks like this, and it's not an uncommon situation, and you're going to align a toric implant with this astigmatism, are you going to align it with the superior, or you're going to align it with the inferior, because there's about 15 degrees difference between those two. So just using clinical acumen, when you look at this, you think, well, I would say that I would line up with the bottom one, because there's more colour there, it's a wider area. The top one doesn't look as influential, so I would line up my toric implant with the lower, inferior half of the bow tie. Well, according to the topography, you'd be wrong, because the topographer's simulated keratometry comes up with 72 degrees, which is actually closer to the superior one. So you might say you're wrong and the topographer's right, but I would say more likely the topographer's wrong and you're right with the clinical acumen, because really the topographer is depending on data from a single placido ring, and if there's any irregularity in that ring, then that's going to be difficult for the topographer to work out what the meridian of that astigmatism is, and even those the calculations are somewhat of a black box. It's very hard to find out how it derives that meridian. So I looked at it a few years ago and said, well, why just use one meridian, because that one ring, because that's kind of historical to try and simulate keratometry back in the 80s. Let's use all the rings and take a vectorial average of all of them, and that way, if there is any irregularity in one or other of those rings, you're going to be washed out by this vectorial average. And we have found, in fact, that if you use manifest refractive cylinder as the gold standard, in other words, that's the cylinder all the way from the front of the cornea to the perceptual component, in an ideal world, all the keratometries will always line up with a refractive cylinder, but in the real world, they're different. So how much different they are depends on how good a measure they are of the corneal astigmatism. So what we found in this paper in 2012, how am I going for time? Okay. In 2012, core T anterior was closer to the refractive, and core T total, which include the posterior cornea, was even closer again. So core T total is a paper that's just coming out in Cornea this month, is shown as a benchmark against topographers. So in summary, ORA is an important component, and it's a red flag when it's more than one diopter. Perceptual astigmatism causes excess corneal astigmatism. It also causes sometimes refractive surprises, which may need a rotation of an implant, or certainly not necessary to the steep meridian. Vector planning optimizes the astigmatic outcomes by reducing that corneal and the overall astigmatism. Core T total is the most accurate corneal astigmatism parameter, and as it says in the corneal paper in Cornea, is a benchmark measure of corneal astigmatism. Thank you.
Question, Dr. Albers, that was very interesting. What's a practical way for a clinician to apply this to our astigmatism management patient? Is there a simple way of doing the vector analysis or some software that we can use?
I didn't catch it.
What is the easiest way to incorporate this into our clinical practice?
How do you incorporate it into everyday practice? Is there vector analysis we can use?
So for toric implants, I use a history of my own incisions. So I'd like to know if you do on-axis incisions, how much flattening effect you get at every point. For toric implants, I've been caught in the past, and many of you may have too, is if you try and reduce the astigmatism on the incision, you can often shift that astigmatism by 10 degrees. So you put the implant at the right place, but the astigmatism itself moves. So now I go for the least flattening effect, most astigmatically neutral, which has been shown to be, in a paper we published in 2015, shown to be the flattest meridian, gives the least effect. And then I will use, in my toric calculator, I will use the anterior corneal astigmatism for the formulae, but I'll use a total power to determine the power of the implant.
It seems this would be, give argument towards the light adjustable lens being a great option, with perceptual astigmatism being different than measured astigmatism. At least at that point, if you do a light adjustable lens, 1 month after surgery, you can treat the patient's perceived refraction and have a better chance of hitting their manifest refraction.
Question is, would a light adjustable lens be useful in this situation when you have perceptual astigmatism?
So the post-operative result, and you do a manifest refractive cylinder, if it's large enough, you need to rotate it. That's probably the primary treatment to line up the cylinders best of all. If you only got a smaller amount left over, then certainly, and they're lined up, then I would look to do a light adjustable lens. Because I wouldn't want to try and do a light adjustable lens to kind of rotate the cylinder. I'd want to have it all lined up so the implant is on the most optimal axis, and then if you want to adjust the magnitude, you can use that for adjusting the magnitude.
Thank you for that interesting presentation.